Good evening. Hello, everyone. The White Army is blessed to have Professor Rajgopal Shenoy sir of KMC Manipal as our mentor today. He is very well known to us as a well known personality and the author of the famous surgical manual textbook. Sir has been guiding the comprehensive clinical classes of surgery for White Army since last year, from last year itself. So welcome to you, sir. Uh,
Thank you. Thank you.
our presenter today is our very own Ashna Raheja. She is a White Army Corps member, third year undergraduate student from BGSGIMS, Bengaluru. She will be presenting a case on a neck swelling. With the permission of Rajgopal sir, I hand the podium to Ashna.
Thank you so much, sir. Very good evening to everyone. Good evening, sir. May I begin the presentation, sir?
Yeah, can you show your video, please, once? So
Yes, sir.
Okay, good. Nice to see you. Good evening.
Good evening, sir.
How are you?
Sir, I'm good.
So no tension. Okay, right?
Yes, sir.
So
Yes,
just
sir.
think that your usual way of presenting the whatever the cases. All right?
Yes,
Yeah.
sir.
Okay, right. Go ahead. All the best. Yes.
Thank you, sir. This is a case of Mrs. ABC, a 35-year-old teacher who's a postgraduate by education and the upper middle class by the socio-economic status by the Kuppuswamy scale. Her date of admission is 14th of January 2021 and date of examination is 16th of January 2021. She complains of an increase in size of the swelling in the front of her neck in the last 2 months. The patient was apparently asymptomatic 28 years back when she noticed a swelling in the front of the neck, which is present since she was 7 years of age, but has grown in size in the past 2 months. Initially, it was 1 by 1 centimeters and now it is approximately 2 by 2 centimeters. It is insidious in onset, progressive in nature, and painless. The swelling moves while swallowing and also moves by protruding the tongue. Sir, next slide, please.
Hello?
Ashna, I've moved on to the next screen. Isn't it visible?
I think she's stuck, I think. Need to, there's a problem of this net problems, no?
Yes, mostly she's having few net issues.
Yeah.
Ashna, can you hear us?
No, I think she's frozen. You can go back to the first slide for the benefit of still she comes back.
Yes, sir.
Yeah, we'll start from the first slide itself. First slide. Yeah, I think for the benefit of everyone here, till our speaker comes back, ABC or Mrs. ABC, you can straight away say that 35-year-old lady. That's enough. So you don't have to say A, B, C, telling Y, X, Y, Z, etc. Okay. So, and again, Mrs., Mr., spelling mistakes may be there. So, simple language, 35-year-old female, teacher by occupation. Yes, postgraduate, coming from the upper middle class, coming to the hospital on 14th of whatever this month.
Sir, sorry to interrupt, sir. Am I
know.
audible, sir, now?
Yeah, just show the video, show your video. Okay. If your video problem is there, just you can switch off your video, no problem. Ashna, you are listening to me?
Yes, sir. Yes, sir.
Ashna? She is there?
Yes, sir. Ashna is here. Ashna? We are not able to hear you. Ashna?
I think that's one message you have to give it to. I know the problems. These are the internet issues. They
Yes.
can probably use the hotspot from the mobile to their laptop or whatever they are using. I don't know. They are experts actually.
Yes, sir. We'll let her know, sir. We'll
Mm.
inform her.
What I was talking is that this is a checklist for you, but in your case sheet in the university examination, we'll be more than happy if you say 35-year-old female, teacher by occupation, yes, postgraduate by education, a upper middle class, coming to the hospital or got admitted on 14/1/2021. This date of examination may not be very relevant. If you write, it's fine. Otherwise, I think it is not required. So, admitted with the following complaints. Learn how to make good sentences. And you have started with the chief complaints here. That is increase in the size of the swelling. That cannot be a, the chief complaint, in the sense it senses that increase in the size of the swelling means there is a swelling there. I can understand the little bit of apprehension in your case, because there's a very long years, long years since birth. Obviously, very congenital swelling. So probably next slide will explain more than that. Can you show the next slide?
Sir,
Yeah,
sorry to interrupt. Am I audible, sir, now?
yeah. Okay. Ashna,
Yes, sir.
I was just telling them what you should have presented is straight away. 28-year-old lady. You don't have to say Mr. ABC, etc. Okay.
Okay,
So
okay, sir.
straight away say 28-year-old lady with whatever teacher by occupation, admitted to the hospital with the following complaints. Your complaint itself you have written as increase in the size of the swelling. So that cannot be a case like that. So what you should have told is straight away, patient complains of swelling in the neck, okay, since 7 years of age. Straight away you can tell. Or maybe
Okay,
since 21 years or 20 years. You can tell, no problem.
okay, sir.
So in which what you can straight away say is that patient noticed the swelling when she was 7 years of age, right?
Yes, sir.
Now tell me one question at this juncture. Is it common for a patient to notice, or probably somebody else? Who is that who notices usually?
So parents would have noticed before the patient.
So there are two issues here. Usually mother picks up this kind of a swelling while giving bath to the children,
Okay,
especially
sir.
those dermoid cysts, sebaceous cysts, and all those things. They are picked up, congenital cystic swellings. They are picked up by mother while bathing the child, etc. Or obviously it is in front here, so obviously father also would have picked it.
Yes, sir.
So what you should have told is swelling in front of the neck for long duration of 27 years or whatever it is. We noticed when she was 7 years old by parents, and then from the time it was not progressing. However, for the past 2 months, it has started growing. That's how you present the case. Okay,
Okay, sir.
right. Now, one or two questions. So, can
Yes,
you
sir.
just tell how you classify some cystic swellings in the neck? Classify.
So on the basis of their location, whether they are in the midline of the neck or on the lateral side of the neck.
Okay, I will give you a clue. That was not my intention, because right now we would like to know the origin of this swelling. So that's why we would like to know. Okay, I'll put it other way. Etiologically, how do you classify the swelling? Etiologic. Think about that. Think. Or what is the origin of the swelling? So obviously it's congenital, correct? Hello?
Yes, sir, it's congenital.
So how do you classify
Yes, sir, it's congenital.
how do you classify the cystic swelling? One, I have given you a clue, congenital. Name some congenital swelling. This is how the discussion starts. Yes.
Yes, sir.
Hmm.
So a dermoid cyst could
Yes.
be a congenital swelling,
Yes.
a branchial cyst,
Yes.
a sebaceous cyst,
Sebaceous cyst is not
and
congenital. 1 minute. Sebaceous cyst is acquired cyst. Okay. Go ahead. Go ahead.
okay, sir. So, and vascular congenital cysts like hemangioma and lymphangioma can be seen.
Malformation. So all of you go back and just analyze. There are many more are there. So first we'll start with the congenital swelling. Now next
Yes,
comes
sir.
the acquired swellings. In that there are so many classification. I myself will give you and you have to give me the answers. One, infectious. Infection.
Yes. So it will be in acquired.
No, I know. What are the name some swellings due to infection, acute infections, which may feel cystic, means, yes, come on.
So viral infection,
No, no,
like
no, 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 hold on. So just simple boil and carbuncle, infective, abscess, abscess,
okay,
right?
sir.
I'm giving you a clue to show that I want a cystic swelling, which is due to infections. So obviously it is acute infection, I said, boil, carbuncle, abscess, etc. Now give me an example of a swelling due to chronic infection, which is a cystic.
So tuberculosis.
Just say cold abscess. Don't say tuberculosis. Cold abscess. Okay.
Okay,
Now
sir.
next, can you give me an example for a retention cyst? Retention. We just now discussed one cyst, na?
Yeah.
Retention.
So sebaceous cyst.
So sebaceous cyst is a retention cyst. Okay. Can you give me an
Okay,
example
sir.
of a what we can call as a exudation cyst? Exudation. Exudation.
Uh,
Hydrocele is an example, right?
okay, sir.
Can you give
Yes,
me an
sir.
example for a retention cyst? We have mentioned exudation
So,
cyst, extravasation cyst, traumatic cyst. Please go through the fundamental classification because it takes long time otherwise. So you need to know about this. Can you give me an example for a parasitic cyst? Parasite. One inside the abdomen, another in the muscles. Yes. Hydrated cyst is one that is in the liver, etc. But
yes, sir.
as far as other things are concerned, cysticercosis. Okay, right?
Okay, sir.
So
Yes, sir.
this you should know the classification, right? Of this, you should know detail about cystic swellings classification. Traumatic cyst. Can you give me an example? Trauma. Trauma.
So can cellulitis be a cause after trauma?
Cellulitis is not a cyst, madam. So what, Ashna, you should try to understand the question. I asked you typically a cyst means, obviously we understand it should elicit some fluctuation, right? Fluctuation.
Yes, sir.
So abscess is the one. Cellulitis does not give rise to fluctuation. Hematocele, yes. Trauma can give rise to hematoma. So get ready with this answer. So you knew a patient who has a long duration of the swelling. We assume it's congenital. It's been slowly growing for the last few 1 or 2 months or 2 years. Now it has become two. Again, this 1 by 1, 2 by 2. Don't be too specific. You can only say approximately. Okay. Approximately it has attained this size, 1 centimeter, 2 centimeter. And why? Who told you this swelling moves while swallowing and protruding? Patient told you?
Yes, sir. The patient told.
Patient told you. Oh, your
So,
patient is, yeah, please go ahead. Yes, you want to tell something?
so because when the patient swallows, it's noticeable that the swelling moves.
And tongue also she mentioned to you.
Yes, sir.
To be on the safer side, don't at least, okay, swallowing, yeah, swallowing is fine because everybody may notice it. She's of course a educated lady, but protruding the tongue, I think you, if patient might have told you, just keep it with you. Okay.
Okay. Okay, sir.
We would like to know at this stage, what is your next slide? Show the next slide. Yeah, before you go to past history, there are many negative points which you need to mention. What are those?
So there is no associated infection.
How do you know infection? Patient doesn't tell you infection. Yes.
So we need to mention about the associated symptoms which can happen in and around the swelling.
No, be specific, Ashna. That simple question I asked you. How do you say it has not got infection? Simple question, no history of pain. Simple. Don't say
Okay.
infection. Infection is judgment. You are going to ask the leading question, did you have pain? That's the first thing you should know. Second question, the patient says no history of pain. Okay, may not be very relevant here, history of trauma. This, I said, it is not very relevant here because you'd like to know the onset, whether insidious in onset, slow progressive, to attain the present size. You'd like to know at this juncture, anytime a rapid increase happened. Rapid increase. When do you get suddenly rapid increase?
So when there's an external influence to the cyst all of a sudden, or
No, just hold on. This is a swelling which you have examined.
yes,
If
sir.
he says suddenly, she comes and tells you, suddenly when I got up today, I find it very big and I have got pain. What do you suspect?
So cancerous condition, sir.
Oh, I mean, don't say that. We
Okay.
are talking about a benign disease now. We are talking, you know, the diagnosis of this, you know, so don't bring the word cancer for your case. Talk about your patient, okay? So what I
Okay, sir.
answer expected is two things here. That is the midline swelling can get infected, then it can become big, or it can give rise to, if it is very thin, some hemorrhage can occur, right? It
Yes,
is
sir.
not a common complication in the uh, here, but thyroid, it is a common complication. So what you should mention is, it is slowly growing to attain the present size, no history of trauma, no history of pain, no history of fever, and no history of sudden increase in the size of the swelling, right?
Yes, sir.
Yes. Now, any other points you would like to ask? This patient has got a swelling in the midline here. So any other would like to ask is, does she have any other swellings elsewhere? Okay. Does she have
Okay.
noticed any other swelling? We don't know. When a patient comes with a midline swelling and tells you it can be something else, don't take it for granted that it's only thyroglossal cyst. So it can be some other swellings. So you need to know, ask the patient, did you notice any other swellings? Can you give me an example of a congenital disease where patient can have multiple swellings scattered everywhere all over the body? Just divert your mind now. Yes. Yes. They have some neural elements, Ashna. Yes.
Sir, so can it be dermoid cyst because it has all the
Okay,
components?
I said multiple all over the body. Answer is a neurofibromatosis. Okay. Multiple.
Okay, sir.
What is that syndrome called as? Von Reckling-Hassen's disease. Okay, right?
Okay,
So you'll
sir.
have a multiple lipomatosis, multiple neurofibromatosis. Yes, in a otherwise an acquired lesions or multiple lymph nodes, lymphadenopathy. A few examples of a multiple swellings all over the body, right? And
Yes, sir.
so please read about that: lipomas, multiple lipomatosis, neurofibromas, etc. All right. Yes.
Yes, sir.
So no other or swellings elsewhere in the body.
Body.
So yeah, please now go ahead.
Continuing with the past medical history, the patient has no other previous history of diabetes, hypertension, or any other noticeable ailment earlier in life, or of tuberculosis or asthma. There is no history of exposure of neck to radiation.
Okay, just hold on for some time now. Um, what is her age now?
So 35 years.
35. So do you think all this, whatever you have asked, what is the relevant thing in your case? Patient is only 35. Nothing wrong in asking diabetes and hypertension. They are not all that common, right?
Yes, sir.
In your patient. Yes, India tuberculosis is common. You should ask history of tuberculosis because the swelling can be due to cold abscess, right? In India,
Yes, sir.
in Indian scenario.
Yes, sir.
Now, history of exposure of the neck to radiation. Which condition you give radiation to the neck?
Sir, if there has been chemotherapy done in past,
See, you have written there
the
radiation. Now you are telling chemotherapy. Don't contradict your own statements. So which condition they used to give radiation, or they can give radiation to the neck commonly, is lymphoma. Okay.
Yes, sir.
So this is relevant only in a few conditions, not in your case. Please do not mention that radiation here. Okay.
Okay, sir.
Please remember, this is a short case for you in the university examination. In a short case, that does not mean that history you should not take. You should take the history, relevant history of onset, duration, progress, any complications, etc. This radiation history is not required. Diabetes, hypertension, asthma, tuberculosis is definitely okay, 35, because we may have to manage her if she's diabetic or hypertension. They require the treatment. Radiation is not relevant in your patient. Please
Okay,
go
sir.
ahead. Please go ahead.
In the family history, there is no history of similar conditions in the family. Personal history, the diet is mixed, appetite is normal, sleep is adequate, bowel and bladder are regular, there is no history of substance abuse, and no history of any known drug allergy.
Yeah, go ahead. I think I'll not give importance there. Yes, go ahead.
The summary, a 35-year-old lady complains of a noticeable neck swelling in the subhyoid region, which is painless, moves on deglutition and protrusion of the tongue.
So just hold on here. 35-year-old lady is very good. Noticeable is not required there. Okay.
Okay, sir.
35-year-old lady complains of neck swelling. When she complains means it is noticed only. Is it clear?
Yes,
Okay.
sir.
Second, swelling in the subhyoid region is not accepted at this juncture. Okay. What
Okay,
you
sir.
can maximum say is upper part of the neck in the midline. Okay.
Okay, sir.
Right. Upper part of the neck in the midline. Okay.
Okay,
So,
sir.
so that it's very clear. So we know exactly where you are referring. You are written there painless and moves on deglutition, which patient has complained to educated patient is okay. All right. The second one, you please remove that from there. Protrusion of the tongue comes later. Okay.
Oh, okay, sir.
So at this juncture, examiner may ask you, what do you think the diagnosis at this juncture?
So the summary indicates towards thyroglossal cyst because it is a swelling which moves on deglutition and also on protrusion of the tongue, if we include that.
As I told you, if you remove that protrusion of the tongue there, so what you can definitely mention, sir, I am thinking in terms of congenital swelling. That word should come. Okay.
Okay, sir.
To word what is expected from you is congenital swelling. Let the examiner ask you what are the congenital swelling you can get in the midline in the upper part of the neck. Then comes your answer should be thyroglossal cyst is most common variety, and then comes some dermoid cyst.
Dermoid cyst.
Here,
Yes, sir.
this is how you need to think, right? Not
Yes, sir.
straight away mentioning that movement on protrusion and deglutition, etc. Okay, and
Okay, sir.
you also should mention there being a congenital, rarely. So sometimes ectopic thyroid tissue can also go in the midline. Okay,
Okay, sir.
ectopic thyroid tissue. Somebody has asked branchial cyst. I think you keep the no, don't mention branchial cyst. Keep it away. There are types of branchial cysts are there. It does not take the priority. It is more of an anterior triangle. So keep it in mind. Thyroglossal cyst has one possibility. Second possibility, dermoid cyst, and the third possibility is a ectopic thyroid tissue. Okay.
Okay, sir.
If it is a dermoid cyst, what type of dermoids you can get there? Yes. If it is a dermoid, what type of dermoid? What do you call them as? A sequestration dermoids, also called as midline dermoid. Okay.
Okay, sir.
You know you know about sequestration dermoids. This means
Sir, in dermoid, I know like there are three types:
yes.
teratomatous,
Uh,
sequestration, and implantation.
So you know the how sequestration means, what exactly happens? You know, any idea?
Sir, as the
Correct,
name suggests, we can have inclusion of epithelial nests under the surfaces.
correct. So when the two halves, two parts of the body, they fuse. So some epidermal cells, as you told, cell nest can get implanted beneath the other one and can give rise to midline dermoid cyst. I think that will not talk now, right? So this is how you go ahead with the diagnosis. Sir, because of the congenital thing, I am thinking in terms of these three diagnoses. Yes, please go ahead.
Continuing, sir, on examination, the patient is conscious, cooperative, well oriented to time, place, and person, and is moderately built. General physical examination, there is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Breast, spine, and thyroid look normal. Weight is noticed to be 64 kgs. Height is 157 centimeters, accounting to the BMI, which is 25.96 kg per meter square.
I just want to keep you informed here again. If it is a short case for you, it is understood that you need not examine the breast, especially in this patient who has come with the midline swelling, because it is neck. I agree.
Okay, sir.
Thyroid need to be mentioned later. There is some importance to that thyroid. I will talk about it later. But spine is all right, cervical spine for a neck swelling. So this is a short case for you. Also, please remember, rest of the things are not required. Be relevant to what has been called a loco-regional examination. It is not
Okay.
just about the swelling, anything connected with the swelling. All right? Yes.
Yes, sir.
Okay. I think I don't have much to say for this. Please go ahead.
So measuring the vitals, pulse 70 beats per minute, blood pressure 124 by 78 millimeter of mercury, respiratory rate 17 cycles per minute, and temperature 98.9 degree Fahrenheit.
Go ahead.
On local examination, inspection done in sitting position with neck region exposed till the mid-sternum. It's a solitary swelling, oval in shape, 2.5 centimeters by 2.2 centimeters. The overlying skin is red and shiny but does not show any scars, sinuses, or ulcers, and it has well-defined borders. The swelling moved upwards on deglutition and protrusion of the tongue. The surrounding skin is seen to be normal. The trachea appears to be central. There are no other swellings seen over the neck.
Do you have the image of this patient? Can you show picture?
Sorry, sir, at present I don't have, sir.
Oh, okay. All right. I think in future, whenever you are presenting some swellings or like that, yes, you need to take the patient's permission, and we will not show the identity of the patient. It's after all a neck swelling. You could have taken a picture so that we get all correct ideas. Now you just go back to the inspection slide. Yes. So that's fine. Neck region exposed till mid-sternum. You are now. Tell me the inspection you do. How to make the swelling more prominent in the neck? Simple question. There is a swelling in the neck. You want to get more details. How to make the swelling in the neck more prominent?
So making the head tilted?
Tilted. Tilted means flexion.
No, sir, like extended towards the back.
So say that now.
Extended.
Extension. Why it becomes more prominent? By doing the extension of the neck. Why it becomes more prominent? That's because, yes, cervical spine undergoes lordosis. Okay? Lordosis.
Okay, sir.
Clear?
Yes, sir.
So when the cervical spine undergoes lordosis, naturally the swelling becomes more prominent, as if it is somebody is pushing it from front. You have written about the solitary swelling. The most important thing which you are not mentioned here, what is that? Tell me. Most important thing you are not mentioned. First slide. First, go back.
Um,
Yes,
so site I have missed.
very important.
Yes, sir. Site,
In,
treatment site.
in, uh, in surgery, diagnosis is often made by the location.
Yes, sir.
No doubt you mentioned that the subhyoidal during your initial presentation. So
Yes, sir.
what you should have mentioned, there is no excuse in the university examination if you don't mention that. So there is a swelling in the region of. Now you can use your anatomical words.
Yes, sir.
In the
Subhyoid
region of
region.
hyoid, in the region of cricoid, in the region of thyroid. Some noise is being heard. Will you please mute everyone? I request all of you to mute yourself except the Ashna. Yes. So, yeah, go ahead. What is that you would like to mention, Ashna, about the location?
So I would say it's a solitary swelling, oval in shape, present in the subhyoid region of the neck.
So you need to say subhyoid region of the neck. Next, you have to say midline or slight deviation. Yes.
Okay, sir.
No, you need to mention. I have not seen the case. So what was in your find? It was in the midline. Fine, it's
So
midline.
it was in the midline, sir.
Okay, all right. There could be a deviation slightly to the left. Sometimes it happens. So there is a swelling in the midline in the region of
The sub.
subhyoid, you said,
Yes, sir.
vertically oval in shape,
Yes,
measuring
sir.
about, you are written 2.5 into 2. I need to know vertically how much, horizontally how much.
So vertically 2.5, horizontally 2 centimeters.
Why it is important?
So that we can localize the swelling, whether it's a horizontal oval or a vertical oval.
In what way it can change your diagnosis? Remember, in this region, if you have got a transversely placed oval swelling, transversely placed,
Yes, sir.
it gives a diagnosis of subhyoid bursitis. Okay.
Okay, sir.
Subhyoid bursitis is transversely placed oval swelling, and thyroglossal cyst is vertically placed oval swelling. Please remember this. Okay.
Yes, sir.
Always remember this. Right. So vertically it measures about 2.5 centimeter, horizontally 2 centimeter. Immediately after that, you should have mentioned surface. Please remember, undergraduate or postgraduate, basic methods, you should not do any mistakes. Location, yes, you are told the number. Yes, extent. Then comes the size you have mentioned. Then comes the shape. Then comes the surface, borders, skin over the swelling. That's how it tells. Now tell me the surface.
So the overlying surface or the skin of the swelling is red and shiny.
No. Again, don't confuse, madam. Surface is different. Skin over the swelling is different. Surface can be smooth, like globe, our Earth globe. We say no. Surface is smooth or
Yes, sir.
irregular. When you walk on the mountain surface or a rough area, irregular. If you walk on big jelly which is put in the road, all big stones, nodular. So don't confuse the matters. Surface, either it is smooth, irregular or nodular. And here in your patient, what was the surface? It
So the
has to,
surface.
yes,
So the surface in this patient was smooth. So it was
it, ha
smooth.
it has to be smooth. I know exactly, but I would like you to say. Understand? Yes.
Yes.
So
Sir,
surface is, yeah, please go ahead. Yes.
so the surface, so we'll get to know on palpation. So
No, no,
can
no,
we
no,
mention?
no. Surface, you have to mention on inspection itself. Its surface is smooth, borders, yes, well defined. Then comes the skin over the swelling. That's what you are written there. Skin is
Okay,
red
sir.
and shiny. What do you mean by this? Why it is red and shiny?
So it is a red indicates that it is vascularized.
You mean to say, in your case, midline, which thyroglossal cyst, does it become vascularized the cause or anything else? Any simple explanation? That is
So it might have become infected.
very
That's
good.
why it's
That
red.
in fact, that is the reason why she might have come to you. So very often these patients may complain to you, I had a swelling, there was some pain, and it ruptured and pus is coming out and it forms so-called the thyroglossal fistula. Okay,
Yes, sir.
please remember, thyroglossal fistula is congenital or acquired?
No, sir, it's always acquired.
Very good. And branchial fistula?
So branchial fistula can be congenital
No,
also.
no, no. Branchial fistula is congenital, thyroglossal fistula is acquired. Okay,
Acquired.
these are all standard questions, MCQ questions. So, and you should not have any confusion about the surface. Okay, surface
Okay,
is
sir.
inspection finding. I will show you later some of my collections and to tell you what is smooth or nodular or whatever. I hope some slides are there ready. Surface is smooth, borders are round. When you say borders are round, well defined, you are written. You need to mention in case all borders. Sometimes you will not be able to get all borders. Then you say, sir, right border is not seen properly, left border is not seen, but I can make out the upper border, I can make out the lower border. This is how you can tell in the examination. Okay.
Okay, sir.
Surface is red and shining. Now, for the time being, just back to the slide, go back. Can you give me one example other than the solid tumor? I want you to understand, in your university exam, you are given a swelling in the thigh. I have given you a clue. Rapidly growing, red and shiny. What is your diagnosis? Tumor.
Um,
Yes. Come on. Somebody has typed. So very vascular tumor, correct what you mentioned. It should be some kind of a sarcoma. Thigh is the most common type. Whether it's a liposarcoma or a synovial sarcoma occurs in the shoulder region, etc. Angiosarcomas are very vascular. So this question is asked to you just to know how much you have read, how much is your knowledge. That's how examiners tend to ask you. Is it okay?
okay, sir.
So can you tell me now what are the vascular tumors you know? Yes.
Sir, the AV malformations that you're asking?
All right. What I asked you was that red and shiny skin you get in with dilated veins in sarcoma. Okay. Right.
Yes, sir.
Can you tell me any condition in the breast where some lady comes with rapid enlargement and some big veins, some shiny skin? You know any condition? Yes. Any condition is called as Phyllodes tumor. Heard of Phyllodes?
Yes, sir, I've heard.
So if you are not read, please at least look at the images in surgery. One look at the photograph gives you 100 information sometimes. So carefully look at the images. Right, overlying skin is red and shiny, shows no scar, sinuses or ulcer. If there's a scar and a swelling, what do you suspect?
Sir, any previous trauma?
Trauma. Trauma, is it
Which
common
was?
in? Is it in the neck? Is it common?
No,
I,
sir.
I will ask you a question. Young lady, same 35-year-old lady, comes to you with a swelling in front of the neck, maybe in the pretracheal area, little low down, and she says spontaneously it has ruptured and forms some sinus. What is your diagnosis?
So can it be a post-operative infection?
What did I tell you just now? Spontaneously ruptured and form a sinus. In India, what is the most common cause for a sinus in the neck? Yes. India, I said, na? Most
Yes, sir.
common.
Sir, tuberculosis?
Tubercular cold abscess. Can you tell me which lymph node come midline in the neck in front of the trachea? Yes. Heard of pretracheal nodes?
Yes, sir. Pretracheal
Prelaryngeal
nodes.
nodes? So
Yes, sir.
tuberculosis has not spared any lymph nodes. Okay, this is how examiners would like to assess from you. When you said no scar, no sinuses, they would like to say no scar means probably healed scar, old tuberculosis, tuberculous sinuses, common sinus in the neck,
Yes, sir.
cold abscess. So if they ask you cold abscess here, your answer should be, sir, from the midline, pretracheal or prelaryngeal nodes can go for a cold abscess. I asked you short duration, 2 months duration. Is it okay? Right? Yes.
Yes, sir.
No scar, no sinuses. But suppose this patient says, 10 years back, somebody has operated on me, you see a scar there, and it has come back with a recurrence, then that was your answer which you gave me first. That is the post-operative recurrence. Okay?
Okay, sir. Okay, sir.
You know that thyroglossal cyst is very known for recurrence.
Yes, sir.
You might have read, no?
Yes, sir.
We'll come to that later after surgery. Okay, well-defined borders. Next slide. Can you? Yeah. Right now, you tell me, why does it move up with the deglutition?
So because it is attached to the base of the tongue. Because when we talk about the path of the thyroid, it starts from the foramen cecum down till the isthmus. So
I asked you 2 questions here. There are 2 things here. Upward with the deglutition is obviously is attachment to the thyroid gland. Okay, right?
yeah,
There are
yes, sir.
two questions of components here. Deglutition is one part. Second one, which you have answered now, protrusion of the tongue, right?
Yes, sir.
So again, repeat why it moves on protrusion of the tongue.
So because thyroglossal cyst forms when there's. Sorry, sir. Am I audible?
You are audible. Please go ahead.
So thyroglossal cyst forms when there's improper descent of the thyroid, and the descent of the thyroid takes place from the foramen cecum till the isthmus area. So if there's a thyroglossal cyst forming, the duct is still attached to the base of the tongue, and that's why when the tongue protrudes, the swelling also moves because the cyst moves inside.
So lower down, the attachment is to the pyramidal lobe. Above, it is attachment. Where exactly attached to the tongue?
So base of the tongue, where foramen cecum is.
What is foramen cecum? Where exactly that lies? At the junction of?
So anterior 2/3 and posterior 1/3 of the tongue.
Excellent, excellent. Anterior 2/3 and posterior 1/3. How does the anterior 2/3 form by? Any idea? Any structure there? Heard of tuberculum impar?
Yes, sir. Yes, sir.
Okay, right. So please go and study about little bit of embryology, what really happens there, and these undifferentiated cells from the top slowly come down, and it's described as a bilobed diverticulum. You know, like diverticulum.
Yes,
Slowly
sir.
comes down and forms 2 lobes of the thyroid, and that is passing in front of the trachea, in front
Yes,
of the
sir.
hyoid bone. Okay, right. So this is explanation for protrusion of the tongue. So swelling moves upwards on deglutition because it is attached to the thyroid gland, and then obviously protruded tongue is due to the connection to the tongue. So very many times you may not be able to get this sign of protrusion of the tongue, especially if it is really obliterated above. Okay, all right.
Okay,
Yes.
sir.
Okay.
Yes, sir.
Next, surrounding skin is normal. Trachea in the center. No other swelling over the neck. What is the other swelling over the neck which you should inspect? That other swelling.
So lymph node enlargements in the neck?
Either lymph nodes or anything else. Look for thyroid gland. Okay.
Yes, sir.
It's not because, please remember, you are examining a female patient. Thyroid diseases are extremely common in female. It may be an incidentaloma. Incidentally, you can pick up a nodule there. Okay, right? So
Okay,
no
sir.
other swelling seen over the neck when they ask you, sir, I am looking for other lymph nodes and thyroid swelling. All right. If you have any doubts up to now, whatever I have discussed, you can ask. Any doubts? Inspection, history.
So till now it's clear to me, sir.
Very good. Thank you. Go ahead with palpation.
On palpation, all the inspectory findings are confirmed. The swelling is warm and non-tender on palpation. The surface is smooth with regular margins. It is soft in consistency and there is no fluctuation seen. There are no palpable cervical lymph node enlargement, and it is not attached to underlying skin or other structures. Transillumination here is negative.
This is your
So,
palpation findings.
yes, sir.
Lot of needs to change, Dr. Ashna. No problem.
Okay, sir.
Yeah. Now,
Okay, sir.
first and foremost, yes, swelling is warm. That is fine. So how to explain that?
So because when we saw an inspection, it was red and shiny. So we suspected an infection. So that
Probably.
could also
Patient,
explain.
and you are written the next is non-tender on palpation. So they're little contradictory to each other. How to explain that? How to explain? We say infection. Now we say non-tender. Your answer should be probably patient has received antibiotics. Okay.
Okay, sir.
All right. Because you give antibiotic to even a breast abscess sometimes, you can become non-tender. What do you call such condition as? Yes, especially in the breast abscess, deep-seated, even thigh abscess, you give antibiotics. What it will become? Antibioma. Okay,
Okay, sir.
antibioma. Antibiotic-induced oma. Oma is a swelling or a tumor. So in such situation, probably is non-tender. You need
Okay.
to measure it. Yes, you are written there. Respective finding confirmed. Smooth surface is fine. Soft in consistency you are written, but you have
Yes, sir.
written no fluctuation. There are something slightly now contradictory again. So when you say soft,
Oh.
what was the size of the swelling you mentioned?
So 2.5 centimeters by 2 centimeters.
So 2 centimeter. If you have a difficult, you know the rules of fluctuation. This is for a basic undergraduate question for the benefit of everyone. What are the cardinal rules of fluctuation?
So I know that if the swelling is very small and it's not possible to check for the fluctuation test,
So,
then we can't comment on.
so in that situation, what test you will do? What has been called as Paget's test. Paget's test. With the tip of the finger, feel in the center. If it is soft, that means it is cystic swelling. Firm means periphery. Somebody has put a slip. Slip sign is not for this. It is for only lipoma. In this patient, when your swelling is very small, you are written that too. So if you have difficulty, you need to mention here Paget's test. Okay.
Okay, sir.
So today your work is to read about number 1, Paget's test. Second, suppose there's a large swelling, mobile swelling has to be fixed. First is mobile swelling has to be fixed. Then
Yes, sir.
you need to use, look at my hands now. You need to use both hands and press like this. That's called as active finger, active. And this, look at the thumb getting elevated. That's called a passive. So it's also called as watching finger and displacing finger, and elicit fluctuation in both directions. All these things are given. Please remember, whenever you have a soft swelling, you can expect these questions. Anything which is less than 2 centimeter size, you can mention Paget's test. If it is more than that, all the soft swellings, you have to say fluctuation. Moment you say fluctuation, examiner will ask you what are the various ways, rules or methods in which you elicit fluctuation. Okay,
Okay, sir.
clear? After that,
Yes, sir. Clear.
what you should have mentioned after that is very important. 3 types of mobility which you need to check now. That
Yes,
is
sir.
again movement with the deglutition. You need to give a glass of water to the patient. Okay, need to give a
Okay, sir.
glass of water to the patient and ask the patient to swallow and check. Number 1. Number 2, tongue protrusion. And
Protrusion.
number
It
3,
so it will move horizontally, but it won't move vertically.
that is called as intrinsic mobility. So if anyone asks you what are the mobility which you need to check for a thyroglossal cyst, your answer should be 3 types of mobility. 3.
Yes, sir.
What are those 3?
The first is to check if it moves with deglutition. Second is to
Excellent.
check if it moves with the protrusion of the tongue. Third is to check the intrinsic mobility. That is, it will move sideways, but it
Excellent.
won't
If
move vertically.
you say all these 3 things, you will get very good distinction marks. Don't worry. But when
Yes,
you
sir.
check the movement with the deglutition,
Yes, sir.
you have to hold the swelling. Okay?
Yes, sir.
And either deglutition or movement on protrusion of the tongue. When he is putting the tongue out, it gives some kind of a tug.
Tongue. Yes, sir.
That is what is very classical of a thyroglossal cyst. Is it clear?
Yes, sir. It's clear.
So all these things are missing in your presentation here. Very important. So
So,
only after that intrinsic mobility everything is over, they may ask you, you are not mentioned plane of the swelling. What is your answer? What is your answer? You are not written there. We want to know whether it's from the skin, subcutaneous, or deep to the pretracheal fascia. Your answer should be any swelling which moves up with the deglutition has to be deep to pretracheal fascia. Okay?
okay, sir.
Clear?
Yes, sir. Clear.
Can you name 3 or 4 swellings which are deep to the pretracheal fascia? Obviously, they move up with the deglutition. Name.
So one is dermoid cyst.
Oh, don't go to dermoid now. How did you get dermoid cyst deep to the pretracheal fascia, madam? It is subcutaneous. No, it's all dermoid. You don't get in the deep to the pretracheal fascia. Your answer should be first is the thyroid swelling. Okay.
Yes, yes, sir.
Second is thyroglossal cyst.
Okay, sir.
Any other which move up with the deglutition?
Sir, laryngocele.
Subhyoid bursitis. And lastly,
Yes, sir.
pretracheal and prelaryngeal lymph
Enlarged
node.
lymph nodes.
Okay.
Yes, sir. Yes, sir.
Yeah. Don't worry. If you read, it will come. These are the 4 common swellings which move up with the deglutition. Okay. Right.
Okay, sir.
Not attached to underlying skin and structures, fine. And transillumination, yes. Whenever you have a swelling which is fluctuant, you need to mention about transillumination. That is nice. Can you give me 2 or 3 or 4 transillumination positive swellings?
Um,
General. Yes. In the neck, child is born with some big swelling, congenital. Cystic hygroma, you heard? Cystic hygroma?
yes, sir. I've heard.
Cystic hygroma. In the scrotum, any swelling is transilluminant. Yes. So, hydrocele, cystic hygroma, meningocele, these are the few transilluminant positive swelling. All right. Yes. Next.
So next is systemic examination. CNS, there are no focal neurological deficits. CVS, S1 and S2 are heard, and there are no murmurs heard. RS, there are normal vesicular breath sounds heard. Per abdomen, there is no hepatosplenomegaly, and it's a non-tender abdomen.
As I mentioned to you earlier, yes, you are written a systemic earlier, specific mention to be made for thyroid swelling. Okay. And no thyroid swelling is palpable. That is fine. Yes. These are not all that important in your case.
Okay.
Hepatosplenomegaly. Per abdomen, soft is enough. Non-tender abdomen is soft is a better word. Okay.
Okay,
Abdomen is
sir.
soft. Abdomen is soft. No hepatosplenomegaly. That's fine. Right. Next slide.
Um, So, yeah.
Yeah, go ahead.
Summary: a 35-year-old lady complains of neck swelling
Yes.
in a neck swelling in the subhyoid region, which is painless, moves with deglutition and protrusion of the tongue. On local examination, the swelling is solitary and oval with a side of 2.5 centimeters vertically by 2 centimeters horizontally. The overlying skin is red and shiny but shows no scars, sinuses, or ulcers. It is warm and non-tender on palpation, soft in consistency. There are no palpable cervical lymph nodes that could be elicited, and there are no associated secondary changes.
You have any more slides?
So investigation and
Yeah. So now you need to give a diagnosis. A midline solitary neck swelling, suggestive thyroglossal cyst with no secondary changes. So what you can say at this juncture, diagnosis is a thyroglossal cyst. Okay.
yes, sir.
Rest of the things you give for the examiner a chance to ask you few questions.
Yes, yes.
Firstly, you tell me, why do you say it is a cystic swelling? See, that is the important thing now. Why do you say it is cyst?
So because on palpation it is soft in consistency.
That is the only one thing you have got now. You don't have any other weapons with you. That is why I told you, you should have mentioned about Paget's test or a fluctuation. Okay, right.
Okay, sir, I'll do that.
Next question they will ask you is, midline is very clear, the midline swelling. Second thing is, why do you say it's a thyroglossal cyst?
So because the three mobilities that we elicited are characteristic to a thyroglossal cyst.
What are those three? Repeat again.
So the first is it moves with deglutition. The second is it moves with the protrusion of the tongue. The third is intrinsic mobility, that is, it moves sideways but does not move vertically.
So I think I mentioned about the tug also, very
Yes, sir.
important. So this is how you say this could be thyroglossal cyst, right?
Yes, sir.
Now a question is asked to you, why not it is subhyoid bursitis? What is your answer?
For subhyoid bursitis, it won't move with the protrusion of the tongue, even though it will move with deglutition.
And shape, I mentioned, it is a
Horizontally oval.
because it is the same location, both are in the same, rare. So why not it is a thyroid cyst if the question is asked? Your answer should be yes. Remember, first I told you in the initially ectopic thyroid, correct?
Yes, sir.
So if at all, if it is a thyroid cyst, it has to be ectopic because it moves with the deglutition and it does not move on protrusion of the tongue out, right?
Yes, sir.
Yes. Now somebody has asked an important question there. Is the thyroid palpable, not palpable, etc.? What is the importance of examining for thyroid tissue in this patient?
So there is a possibility that the only functional thyroid that is present is in the cyst itself. So before removing the cyst, we need to know if the thyroid is present or
Very
not.
good. So that is an importance of knowing. In case on clinical examination, if thyroid gland is palpable, it is clear, no? Right?
Yes, sir. Yes,
It's
sir.
very clear. Suppose if the gland is not palpable, then you, whatever you said just now, before you excise, at least the minimum, we need to know the ultrasound of the neck. Okay.
Yes, sir.
One more important thing you always, all the students should remember, whenever you have one anomaly means like this. This is a thyroglossal cyst is one anomaly. You need to look
Yes.
for connected other anomalies which are possible. And one of them is a lingual thyroid. What is lingual thyroid? Lingual thyroid. You know that? Heard of that?
Yes, sir. Yes, sir. Yes, sir.
Thyroid has not descended.
Yes, sir. It's
So in the region of same base, what you mentioned, foramina cecum, there is a tissue there, which is elevated little bit of, not that common. And Thyroid is not present in the neck. So
Yes,
always,
sir.
whenever an anomaly is there, they may ask you, did you examine the oral cavity or tongue for anything? Your answer should be to rule out a lingual thyroid. Okay?
Okay, sir.
Lingual thyroid anomaly. Yes. So diagnosis is thyroglossal cyst, I think fairly straightforward. By
Yes, sir.
classical congenital in origin, that's a etiology is congenital, etiology. Basically, there is a cyst is going to secrete, it is lined by epithelium. The reason why it becomes obviously slowly enlarging in size, it gets infected because there are lymphatic tissue in the wall, like a branchial cyst. Thyroglossal cyst also has got lymphatics in the wall, so it gets infected. And to say thyroglossal cyst, those are the points which are told. The differential diagnosis has to be here. The cyst has to be ectopic thyroid tissue, thyroid suboid bursitis, and importantly, if this cyst is at a lower level, can you give me some differential diagnosis? Say at the region of thyroid gland. That is the next position. You understood my question?
Yes, sir. If the cyst is at the location where the thyroid is.
It has to be differential diagnosis has to be cyst in the thyroid, correct?
Yes, sir.
And parathyroid swellings. Okay,
Okay, sir.
but to keep it in mind, parathyroid. And at that juncture, if they ask you why not lymph node, what will you say? Why not lymph node? Your answer should be lymph node will not move with deglutition or protrusion of the tongue. Okay,
Yes, sir.
right. So that's all about the differential diagnosis here and for this situation. And quickly tell me what are the 5 sites where you get the thyroglossal cyst?
So the most common site is the one which we have, that is the subhyoid site.
Yes. Other sites?
So apart from that, it can be present at the level of the thyroid cartilage. It is the second most common site. Apart from that, it can be present at the suprahyoid region or at the foramen cecum or at the level of the cricoid cartilage. And the last is at the floor of the mouth, sir.
Okay. Now you tell me, proceed with the investigations.
Yes, sir. So, next slide.
Somebody change the slide if it has been done. Yeah.
So in investigations, we need to check for the thyroid function tests.
Please just
and know
hold
the
on.
value.
Just hold on. In the university exam, when they ask you what investigation, your answer should be, sir, I will do routine blood test. That is okay for the general health. But importantly, don't mention T3, T4, TSH. You only straight away ask for ultrasound of the neck. Okay?
Okay, sir.
Right? Ultrasound of the neck. The ultrasound says thyroid gland is still palpable there and this is a thyroglossal cyst. You don't have to do the T3, T4, TSH. Okay? Right?
Okay, sir.
Yes.
Yes, sir.
And you have written the FNAC, you have written the
Yes.
X-ray of the neck, you have written radioiodine uptake scan. None of them are required in your case where the thyroid gland is palpable. Okay?
Okay, sir.
X-ray of the neck, such a small swelling, don't irradiate the patient. Radioiodine uptake scan is not required if ultrasound picks up a thyroid tissue. So these are all, don't get into trouble in the exam. Simple, sir, I will do blood tests. You mentioned about diabetes and hypertension. Yes, yeah, I would rule out if at all, if it is there. And I'll do ultrasound of the neck. FNAC, ultrasound guided, you can always mention, no harm. And for postgraduates, rarely, very rarely, thyroglossal cyst can turn into papillary carcinoma.
Carcinoma.
So,
Yes, sir.
if at all examiner asks you any importance of FNAC in your case, in case, otherwise, it's a clinical diagnosis, location, and 3 types of movements, and congenital history. You don't require much investigation. You can stop at ultrasound ultrasound is always extended surgical arm, right? Okay. I hope it's clear. Any
Yes,
doubts?
sir.
Any doubts?
No, sir, no doubt.
Okay, go ahead. Treatment.
So in treatment, we do cyst trunk operation, which is basically removing the entire cyst along with the thyroid gland.
Can you explain a little more than that? I have expect you to talk little more than that. Yes.
Okay, so sir, it's a thyroglossal cyst, which is because of the thyroglossal duct. So we want to excise the entire thyroglossal duct, and this will involve the removal of the
Yes, correct.
cyst along with the hyoid bone.
So what I want the answer are three things here. Your cyst is at the subthyroid level.
Yes, sir.
So it has got a fibrous tract up to the pyramidal lobe, right?
Yes, sir. Yes,
So
sir.
it has to be removed. Cyst has to be removed. Then if it has gone through the body, most of the time the hyoid bone rotates during the developments. That is why the tract goes behind the body. Sometimes it's very close there. So portion of the body of the hyoid bone and above the level may go up to the foramina cecum. So to facilitate that, anesthetist or the surgeon's left hand, you can push the tongue down so that core of the tissue, core about a centimeter or so, it has to be removed. In fact,
Yes,
some
sir.
people take little more because thyroglossal duct has got a ramification or branch sometime. So
Yes, sir.
incomplete excision can cause a recurrence. Okay.
Yes, sir.
So your answer cyst trunk is correct. So what you need to tell is three things here: entire thyroglossal duct tract, including the surrounding tissue, core of surrounding tissue, with the portion of the hyoid bone. Okay.
Yes, sir.
Earlier, the people removed a portion of the small portion of tongue also. That central portion, if it is removed or comes out, just put a suture with absorbable suture that completes the answer. So why you want to take out this track? What is your answer?
So to prevent recurrence, because if we don't remove the entire tract, there can
Yes.
be a recurrence from the side branches of the thyroglossal duct.
So that is the reason why you would like to excise the entire tract. So
Yes, sir.
I think what are the indications for surgery?
So before we do the surgery, we need to do a thyroid scan.
No.
So to see.
No. Don't. Again, don't say thyroid scan. Say ultrasound scan of the neck. That's a different. I asked you indications for surgery. Indication. Why do you want to remove?
So when it's becoming painful to the patient while swallowing.
No. There will not be pain. Your answer should be secondary infection of the cyst. Right? You said no. It's warm and all.
Yes,
So
sir.
if it ruptures, what it will form?
So fistula.
Thyroglossal fistula, cosmetic. If she's a lady, working lady, you said teacher, right?
Yes, yes, sir.
So you need to know that very important is indication is infection, cosmetic purposes. There's another thing in front of the neck. Yes, rarely, very rare, malignancy, papillary carcinoma, thyroid. So important indication is actually it's infection and cosmetic, right?
Yes, sir.
So that concludes our today's session. If you have any question related to this, you can ask. But before we conclude, I have got a good slides presentation. So if firstly, any doubts about this question, somebody can ask. Before I start sharing my screen, anyone can ask any questions related to your case or doubts or how to conduct in the exam, anything, feel free to ask. All very clear? Everyone?
Yes, sir. It was clear.
Huh. Can I share some screen coordinators? Anybody is there? White RB?
Yes, sir. I guess you can share your
Yes,
screen,
sir.
sir.
Sir, you can
Okay.
share, sir.
Yeah. Okay.
Yes, sir.
So I'm going a little fast now. Can I see the screen?
Yes, sir. Your screen is visible, sir.
Yeah, I will not go in detail because each one of them will take a lot of time, but just for you to understand that you need to know this by heart. Very commonly asked question from top to bottom, from midline. What swelling will come where? See where your thyroglossal cyst will come. So it is from here to down. I will not go to Ludwig's angina, but I will straight away go to enlarged nodes in the submental region. See here, this. If you are given a case of a nodes here, you need to think of, look into other nodes. Here, see the nodes? So this is
Yes, sir.
typical of a lymphoma. Lymphoma, is it clear? So look
Yes,
at
sir.
that. So that's how, if the nodes are matted here, it is tuberculosis. But on the other end, if your patient is an elderly lady with the carcinoma, tip of the tongue or floor of the mouth, the nodes can be due to metastasis. Okay?
Okay, sir.
So you need to think about three possibilities whenever you got a lymph nodal swelling. So that's in the midline. Now, see that oral cavity, this man had malignant melanoma. Can you see that pigmented lesion? Right?
Yes, sir.
So this is just to show you that source is tongue here and node is hard, midline. Now just look at that, lady. You see here now, swelling is here. And look at that swelling, large swelling in the oral cavity, right? So
Yes,
this is
sir.
how you give a diagnosis. Now comes the dermoid cyst, which we are talking about, midline dermoid, that sequestration. Look into the oral cavity. See this? Can you see this?
Yes, sir.
Beautiful swelling there. The three diagnoses. You have a ranula, which is brilliantly transluminant, sublingual dermoid, and a thyroglossal cyst can not necessarily come here, but this is not the classical site, but as high up can get in the floor of the mouth, right? So now I mentioned about suboid bursitis, that is to show
Yes, sir.
you transversely placed oval swelling and vertically placed oval swelling. Look at the difference. This is thyroglossal cyst and this is suboid bursitis.
Bursitis.
This is that swelling. Another swelling, which is thyroglossal cyst. I have brought it just for you to, for the purpose of everyone to know. This is what I mean by smooth surface. Is it clear?
Yes, sir.
Later, palpation it may turn out to be irregular. That's a different issue. Surface is smooth, borders are round, vertically placed oval swelling, moves with the deglutition, moves on protrusion, and the tug. That's the classical. That's what it moves up here. And a large cyst which somebody had incised. So a small skin fold-like thing has appeared here. What has been called a hood sign, like a snake hood. It's called as a hood sign. All right. That's the various sites. That's the thyroglossal cyst. I just want to show you this video. So to tell you the classical movement with the tongue, right?
Yes, sir.
So I don't have to tell she's a young child. See, age is in favor, congenital, midline swelling, moves on swelling, moves on protrusion of the tongue. So you make a diagnosis of a thyroglossal cyst. Now, look at that. I can imagine your patient would have come like this with that infected something like this. I'm not sure. So that's the classical infection, redness. I saw that. So maybe the whole thing was pus. That's the reason why I could not elicit fluctuation. Such a small one, you do that. What is the test? What you need to do?
Sir,
Paget.
Paget's test.
Good. Yeah, then you come down midline, you get a thyroid swelling, right? See here, that's the all thyroglossal cyst is here. Suboid bursitis is here. This is thyroid. Midline is isthmus. So midline is isthmus. Look at that. Isthmus swelling in relation to isthmus. So nodule of the thyroid or parathyroid, they all can come down. Still you come down pretracheal and prelaryngeal nodes. I mentioned to you pretracheal and prelaryngeal nodes. They can be enlarged in papillary carcinoma thyroid or larynx, etc. And I mentioned to you, rarely tuberculosis. And lastly, just for you, can you see some swelling there?
Yes, sir.
What is this area called as? Suprasternal space of burns.
Burn.
Burns. Burns. Suprasternal space of burns. So you need to know from chin up to here without confusion. Ludwig's angina, you start from there. Then matted nodes or tuberculosis or whatever lymph nodes, subarachnoid bursitis, thyroglossal cyst, cyst in the thyroid, parathyroid swelling, pretracheal, prelaryngeal nodes here, and come to the suprasternal space of burns. Can be a tubercular cold abscess here. There are lymph nodes here, or a lipoma, or sometimes even you get some pulsatile swelling there, which can be due to even a aneurysmal formation, aneurysm there. Now look at that swelling here. Just because it is transverse oval swelling, somebody said it is the bursitis. Do you have any diagnosis in this patient? One look of this. Can you guess anything there? See his face. Look at that. Lot of sebaceous cysts he has got. Lot. Can you see the spots?
Yes, sir.
This was a large sebaceous cyst in the skin. That's why it's important to know plane of the swelling. Plane of the swelling. So it is that's a different issue. So these are few important swellings which you need to know whenever you are given a midline swelling as a differential diagnosis. Right? Okay.
Yes, sir.
So, any questions related to this? Whatever I have discussed now. White Army, do we have some more time? 10-15 minutes.
Yes, sir. We have time, sir. Yes.
I just want you to, everyone should be know. Today what we have seen is a midline swelling, but for you can see the slides now.
Yes,
Yes,
sir.
sir. The slides are seen.
Yeah, good. So what? Just look at that once. Whenever you are given a swelling in the neck, if you say patient complains of swelling in the neck, your grandmother also will tell there is a swelling in the neck. You have studied your anatomy well, so you need to know which triangle, because if you say midline, already we have told you the differential diagnosis. If you say submandibular triangle, or if you say carotid triangle, or you say posterior triangle, you have some other diagnosis. So always remember, whenever you are given a neck swelling, you need to know where it started, how much it has extended, what are the structures which are present in this triangle, what is the pathology, what are the common swellings, and what is the pathology which can occur in other area. So every one of you should know. I hope you understand the basic surgical anatomy before you read about the neck swelling, right? So how do you classify the neck swelling in general? Cystic, solid, and pulsatile. Now look at that. How do you elicit the fluctuation? Look at these fingers. Ashna, you are there.
Yes, sir. I'm there, sir.
See how you hold the fingers there. 4 fingers are held. Facing the swelling. It's a large swelling in the nape of the neck. And press with this watching fingers and see the thumb getting displaced, and you elicit the fluctuation in both direction. Small swelling, press in the center. Sebaceous cyst, press. It gives you an impression of a cyst, but it is not a cyst in the sense, classification wise it is cyst, but it does not give rise to fluctuation because it is putty in consistency. So that is why you get that kind of a sign of what has been called as indentation. This is indentation, right? So
Yes, sir.
very important finding of palpation which decides your case for the cystic swelling. Because if you say fluctuation, check for this. Small swelling, check for check for Paget space. And for a sebaceous cyst, you find it yielding, that is causing some indentation, and that is sebaceous cyst. See that classification I asked in the beginning, classification of the swelling.
Yes, sir.
So look at that. So you need to know it properly. There's a very common question which is asked. So no compromise even for UG or PG. Not to know this, how do you classify cystic swellings? So need to be very clear about that. So it gives you some idea. What is ranula? What is sebaceous cyst? The duct is blocked. Ranula is also a retention cyst. What is the ovary? Is a distension. Distension is a hydrocyst. So everyone should know about this. How to classify cystic swelling? Yes, already you have mentioned about the inspection findings. So whenever you are given a case of the neck swelling, look into these 5 P's, which may tilt your diagnosis very often. Is there a punctum? See that? That
Yes,
means,
sir.
what is the diagnosis? Yes, sebaceous cyst, also called as epidermoid cyst. Okay, right?
Okay, sir.
Now look here. In fact, I can't demonstrate that here. He had a pulsations. And if the pulsations, what was the diagnosis? The vascular one. So, AV malformation. Okay,
Yes, sir.
AV malformation. Look at this swelling here. It was a large, hard nodes with the central degeneration, but skin is involved, puckering. So these were metastases. Metastasis, when I say secondaries in the neck. Secondary means primary has, is there some other place? Let us not worry, that's another topic. What is this? Can you see this? Ashna, you are there?
Yes, sir. I'm there, sir.
What is this? Do you drink coffee?
Yes, sir. I do.
So this is how the examiner gives you clue in the examination. Don't say I drink coffee. You say Kephile spots. Okay.
Okay. Okay, sir.
They are classical of von Recklinghausen's disease. Okay. And lastly, just see that hard swelling there and folds of the skin where the platysma is involved. So this is your checklist. Whenever you are given, you are talking no inspection wise. What can I say here? Both together, you can say nodular surface. Here it is smooth. This is nodular, whereas here it may be irregular. Okay. Now then mobility, everything you have mentioned. Yeah, this is what is fluctuation. And whenever you have a fluctuant swelling, next you need to do what is this called as transillumination.
Illumination.
So you need to do a transillumination. All of you should have a transilluminoscope. On X-ray, if it is there, roll it and use the torch, working torch, not your mobile torch. Mobile torch, it may be difficult to put that. So that's how you elicit the transillumination. Very brilliantly transilluminate. I asked you this question. What are the
Yes, sir.
swellings that are transilluminant? This is the first diagnosis. This was a lymphangioma. It's very thin walled. It's brilliantly transilluminant. Then, of course, this is the list for you. Ranula in the floor, meningocele in the back, epidermal cyst in the scrotum, hydrocele. Interglossus cyst, I put a question mark. Rarely, if it is a thin walled cyst, it can also give rise to fluctuation. Otherwise, in general, branchial cyst, thyroglossal cyst, they contain some desquamated epithelium, so they do not give rise to fluctuation. They do not give rise to transillumination, but they do give rise to the classical fluctuation, right? So you have a cystic swelling in the examination tomorrow, but transillumination was negative. So this is your list. Cold abscess, lipoma, hemangioma, aneurysms, branchial cyst, etc. Last two not for you. So this is how you anterior triangle. Somebody has been given a branchial cyst case. So that I will show you. Yeah. So no 1 minute before that. I mentioned to you about the plane of the swelling. In the midline, it is very easy. You move with the deglutition means it is deep to the pretracheal fascia. But imagine this lady has got a swelling here, anterior triangle. Here the swelling. You can see a node there. You want to contract her left sternomastoid. You ask the patient turn to this side and look at the hand there, giving a counter force. That's how the sternomastoid gets contracted. And if it becomes less prominent, it is deep to the sternomastoid muscle. This is how you look at the plane of the swelling, right? And if you sometimes you say firm in consistency, then don't say I have done fluctuation. Okay? Hard in consistency, don't say fluctuation. Fluctuation should be elicited only when you say soft. Tomorrow you have a sarcoma, don't say it is not fluctuant, or bone tumor, or anything, neurofibroma, salivary gland tumors, parotid. If it is solid swelling, if it is firm or hard, don't say it is fluctuant, right? So this is our some of the very important basics. And once you say fluctuation is over, next you want to rule out a vascular swelling, a soft swelling. Then look at the vein with the two fingers are kept there. They are straightly elevated. It is transmitted pulsation. If it is separated, it's expansile. That is aneurysm. Peripheral aneurysm. It may not be very important case for you, but neck sometimes in the carotid or subclavian or in the leg in the popliteal region, you may encounter this situation where swelling is soft, it is fluctuant, transformation is negative, but then it was showing fluctuation. Sorry, the pulsations. Look for pulsations, and if fingers are elevated, is transmitted, elevated and separated, then of course we call it as expansile. That means it's an aneurysm, right? So that's how the classification for the swelling in the neck, broad classification of a solid, cystic, pulsatile, and you say transformation is positive and negative for the cystic swelling, and that's how you go and classify, right? So I think I'm going to stop at this stage. Ashna?
Yes, sir.
Yes. So for all the other people, maybe some other time we'll discuss this anterior triangle or neck swelling and posterior triangle. So if one of you can prepare well and come for one of the neck swellings which have been numbered here, any swelling in the neck for that matter, lateral neck swelling, we will discuss next time, right?
Yes, sir.
So I'm stopping at this stage and I ask any questions. Anyone, you have any doubts, feel free to ask. Lateral neck swellings we will probably discuss in some other time.
Yes, sir.
Sir, there don't seem to be any doubts in the chat as well as in the YouTube, sir.
No, they.
So your class was too comprehensive, sir. It cleared many of our doubts before there was any doubts.
No, I need to know the some little bit of level of which a student is present, in the sense, because I know this is for undergraduates, so I need to really go into the basics rather than talking straight away to the diagnosis. So that's how I gave you some preliminary idea about this transillumination, fluctuation, pulsation, etc. These are very basic fundamentals, which if you know, you will pass. Passing is not at all a problem. But now onwards, to get more marks, you need to put little more effort. So
Okay, sir.
whenever the class, whenever you are presenting, spellings means you need to know, read anterior triangle, posterior triangle, as well as midline. Next class will do that. That's all from my side. Yes.
Thank you, sir.
Thank
Thank
you,
you
sir.
so much, sir.
Thank you. Thank you.
So it was indeed a comprehensive clinical class. Thank you, sir, for teaching us and guiding us through this very important and interesting topic. So need your blessings throughout. Also thankful to Miss Ashna for preparing and presenting the case and making the discussion progress in such an active manner. Finally,
Thank you, sir.
thanking all the Zoom participants for their active participation. Thank you, everyone.
Thank you. Thank you.
Thank you,
Ashna sir,
sir.
we can close the session now.
Thank you.